Thank you very much. And we will be introducing our last speaker, Dr. Roger Hartl from Cornell Medical College and US Presbyterian Hospital in New York City. Dr. Roger Hartl is a professor of neurosurgery and director of spinal surgery and neurotrauma. He is a leading name in the world in the minimally invasive neurosurgery and spine surgery and requires no introduction. We are absolutely honored, Roger, that you can join us for our panel. You can go ahead and do the slide share now.
Great. Well, thank you so much for having me. I've been listening to some of the speakers, and I really want to congratulate Anila and the organizers for putting together a great online symposium. I'm very honored to be part of this. And I was asked to talk to you about MIS TLIF, and I'll be happy to do that, of course. I'm a neurosurgeon. I do mainly spine surgery. I'm located at Cornell, New York Presbyterian Hospital in New York City. And a fair amount of my practice is minimally invasive spinal surgery. And I want to talk to you about MIS TLIF, which really has become one of the main MIS procedures that surgeons do. And there's fairly good data that it is a very helpful, very successful operation especially for degenerative issues, of course. First introduced probably in the early 2000s by Kevin Foley, who really pioneered this operation, and then really developed further by many surgeons. And now I think it's a total standard operation that we do several times a week in appropriate patients. Now, where's the benefit of MIS? I just want to show you this because it really illustrates the importance of MIS TLIF and some of the principles that are behind this operation. If you look at open traditional surgery and you plot the complexity versus invasiveness, you can see that it goes up pretty steep, and procedures, as the complexity increases, the procedures become pretty invasive at an early stage. Now, with minimally invasive surgery, you flatten that curve. And that's the benefits, or the difference between those two curves. That's really the benefit zone for MIS surgery. And MIS TLIF is right in the center. So I think it really has become a workhorse procedure for those of us who do MIS surgery, together with the translumbar or OLIF types of procedures, and obviously the MIS decompression through tubular or endoscopic retractors. So just to show you that it is such an important part of what we do as MIS surgeons. Now, I also want to talk, as I walk you through my workflow for MIS TLIF surgery, you will realize that I use a lot of navigation. And I know that navigation is not available to some of the participants probably of the course at this point. Maybe some of you have it already. However, I know that the technology is evolving. More and more surgeons are going to have it available, and that's why I want to give you a little bit of an idea as to how to integrate navigation into your MIS TLIF surgery, and really into most of the fusion procedures that we do, and even some of the decompression procedures. Now, I've been using navigation for 15 plus years. First in brain surgery, and then when I started doing spine surgery, we really translated that. And we use it now for about 75% of our cases. So there's hardly any fluoroscopy being used, nobody wears lead. And we use navigation really from start to finish. We use it to plan the skin incision when we do our cases, to insert the screws, to place the tubular retractor, to do the decompression and so forth. And it's like everything with technology, you kind of become used to this, and you extend the applications. We published our experience with navigation for MIS TLIF surgery a few years ago. And as I mentioned, so I'm going to walk you through it. Now we use this type of navigation, which is an integrated system that combines navigation with a true intraoperative CT scanner. But you can do the same thing with fluoro-CT type setups. Now, the workflow for MIS TLIF that I use currently is depicted on the slide. I insert the reference array for the navigation into the iliac crest. We get a spin, and then we navigate the screws. We insert the screws through 2 skin incisions. It's very, since we don't use fluoroscopy, obviously, you have to make 100% sure that you trust the accuracy of your navigation, and there are certain tricks to do that. And then once we have inserted the screws, we'll put in the tubular retractors. We use navigation for that. We do the discectomy, we do the cage, and then at the end, before we put the rods, we get a final spin to make sure that everything is accurate. That's the setup in the operating room when the patient is being prepped. So that's the intraoperative CT scanner, anesthesia, the scrub nurse. We have the navigation unit here. I use a microscope. As you can see, there's no fluoroscopy needed because, again, we rely on navigation. And you have to become comfortable. It's not something you can just start doing. You really have to go through some efforts to make sure that your navigation is 150% accurate. When we get the scan, everybody leaves. So there's no radiation to the surgeon or the staff. This is the patient being taped to the operating room table for navigation. Again, we rely on navigation, so I tape the patient down. All the soft tissue is under tension, and that increases the accuracy of the navigation. Obviously, I mark the iliac crest here, and then we get the spin and start navigating. The iliac crest, the reference array is attached to the iliac crest here via 2 pins. I mark the midline here. The iliac crest is marked just for reference when you put in the pins. That's when we get the CAT scan. So we we cover the patient, and then we start the operation. And as you can see here, from the very beginning, even the skin incision is being planned with navigation, and you plan the skin incision in a perfect trajectory for the pedicle screws. So an elongation of the pedicle trajectory to the skin. You make the skin incision here, you make the fascial incision here, and then you have a perfect trajectory into the pedicle. We call that don't fight the fascia. If you make the skin incision here and the fascial incision over there, you'll introduce potential inaccuracy when you put in your screw because you have to push against the fascia, and that may change the anatomy. I'm just giving you some of the little tricks and tips that we kind of learned over the years to really maximize accuracy. Now, several companies now have these types of pedicle screws available. These are single pass pedicle screws. As you can see here, they incorporate a K-wire into the tip. They have a very aggressive screw tip. We navigate this pedicle screw, and that allows us to really cut down on the number of instruments that we have to navigate. So there's no Jamshidi needle, there's no awl, there's no tap. Everything is incorporated into this pedicle screw. Makes it very easy and makes it very cost effective and time effective to insert this pedicle screw under navigation. So so that's the pedicle screw. It's navigated, as you can see here. That's the tip of the pedicle screw, and we register it for the navigation system. We have a small skin incision here. We tap, so the KY that's sticking out attaches to the bone, and then we insert the pedicle screw under direct navigation. You can see here that you really have to obviously make sure that you penetrate the bone. So we've used this pedicle screw now maybe for 1.5 years or 2 years, and we've been very happy with this. Every pedicle screw takes about 2.5 minutes, and is very accurate overall. Now, once we have the pedicle screw inserted, we'll harvest a bone from the iliac crest, and again, we use navigation for that. You can navigate your little harvesting device through the same incision. You've got some nice bone graft for your interbody fusion later on, and then you place your tubular retractor. So again, for that, we use navigation, as you can see here. You make a second fascial incision that's more medial from the incision that you made for the pedicle screws, and then you place your tubular retractor. And now these are some drawings from AO Spine. We worked with AO Spine on teaching material for MIS TLIF surgery. And so this shows you the MIS TLIF on the right side at L4, L5. So you place your tubular retractor, and then you see the facet joint here under the microscope. I use this I do this with a microscope, but you can do it with loops as well. And then you start orienting yourself. And again, you can use navigation for this. It sounds a little bit, maybe initially, if you haven't done that, it sounds maybe as overkill. However, once you start using navigation, it comes in very handy. For example, here you're going to drill and you want to get into the pars to disengage the intra-articulating process. So you can look at the navigation. It shows you the pars, so you know exactly where you have to drill to from the inferior edge of the L4 lamina, for example. So you do that, you drill from the inferior edge of the L4 lamina towards the pars here. You remove the piece of bone and then you use that for your fusion later on. And this, by the way, is exactly the same that you would do with open TLIF surgery as well. So you try to remove the facet joint to get access to the disc space and then do a decompression. The next step then is you can do with a ball tip or with navigation. You can find the L5 pedicle here and you drill, or you can use an osteotome. And again, you disconnect the superior articulating process here to harvest that bone for your fusion. In this case, we use navigation to find the pedicle. Then you see space, you see the traversing nerve root here, the exiting nerve root there, and then you start working on your discectomy. And here also navigation can become handy, especially in patients who have a very collapsed disc space, or where it is hard to really get into the disc space. You can use navigation to find a step off in patients where there is significant spondylolisthesis. And then you can confirm that you actually got into the disc space and are in the right position. At that point then, once we've done the discectomy, we use the bone that we harvested, we grind it up, and we put it into the disc space and into the cage. And that's planning of the cage here. Again, you can simulate the cage, the positioning of the cage exactly in the middle, and that's where navigation also comes in very handy. And that's placement of the titanium cage through the tubular retractor. This is the bone graft that has been placed into the disc space. Now we put the cage in here, and again, we use navigation to make sure that we have nice placement. Now, a lot of patients will require decompression. Some patients may have severe lumbar spinal stenosis. So in those patients now, you want to do a decompression of the spinal canal, the thecal sac, and that's when the over-the-top decompression comes in. So now we're rotating the table away and we're angling the tubular retractor to get access to the inferior portion of the spinous process and then eventually to the contralateral lamina. We leave the ligamentum flavum sometimes intact, or we protect the dura with suction tip, and then we drill and decompress the spinal canal. So that's essentially what we do here. We get a bilateral decompression from a unilateral approach, and we call that over-the-top decompression. Navigation can be helpful here to confirm that you made it all the way to the other lateral recess, and you can actually do a contralateral foraminotomy there. And again, navigation can help you to confirm that. There's even a movie that was made about this, Over the Top. My joke for the day. So, and then finally, then we get a scan. Once everything has been inserted, we get a scan to make sure that the screws are fine, and then the rods are being placed. You can also get a reduction of the spondylolisthesis if you want. In this case, we didn't do that, but there are other things you can do now. There are some pedicle screw systems available. In the US, there was a big deal to get the pedicle screws that are actually suitable and FDA approved for cement injection. Now they're available. I know in Europe and Asia, you've had those for a long time. Or sometimes we have patients who have two-level lumbar stenosis, and in those patients, we will do, for example, if they have instability at one level, but no instability at the other level, we will do an MIS TLIF at L4-5 and just a tubular decompression at the level above. And we call that 1.5 TLIF. We just published that. And that works very nicely and really avoids a two-level fusion in those patients where it's not needed. Sometimes, however, you have to do a two-level TLIF. And that's the case here where we did a Tandem Slalom MIS TLIF, We had 2 microscopes available, so the assistant or the fellow worked on the other side. So did one side of the TLIF, I did the other one. We put the cages in from opposite sides, as you can see here. So that's where MIS becomes really interesting. Once you can really mix and match and use different types of technology and hopefully cut down on some of the time and make this whole MIS surgery more time efficient, because as you know, if you have to do everything yourself, it takes quite some time, even if you have experience and if you're good. So we wrote up our experience with navigation in spine surgery, and was published in World Neurosurgery a few years ago. And we found that overall in our spinal practice, and I'm talking about not only my practice, but also my colleagues here at Weill Cornell, we eliminated fluoroscopy really in about 75% of our cases. We think that navigation makes surgery safer. There's really no malplacement anymore, or if there is malplacement, you can pick it up while the patient is still in the operating room and therefore fix it. It's very time efficient once you get used to it, once you have your team on board. And it is cost effective because it prevents revision, or it avoids revision surgeries, which are very expensive. Facilitates some of the more complex procedures and especially MIS. So I also, at the end of my talk, I want to make you aware of an effort that is ongoing right now through AO Spine. And so we're putting together an MIS curriculum that will be taught at all the MIS spine courses worldwide through the AO. And we talk about MIS TLIF procedures. We talk about basic skills such as using the microscope, navigation, how to fix a CSF leak through a tubular retractor. We talk about endoscopic procedures. So if you have an interest in getting involved, or if you have, we're still at a relatively early stage, let me know, and I'm happy to share some more information with you, or look out for this at some of the upcoming AO Spine courses, maybe next year, where this will hopefully be put into practice. So, and for those of you who want to come to New York, we have our 13th MIS Navigation Augmented Reality Endoscopy course in December at Weill Cornell. Let me know. I'm happy to get you involved, and thank you very much for your attention.
Okay, thank you so much, Dr. Roger Hartl, for a wonderful talk, and also for letting us, all the participants, know that if they are interested in pursuing a workshop in MIS, they can either go to your institute or can register through one of the AO Spine in the nearby regional areas. This ends our symposium on minimally invasive spine surgery. I am thankful to all the organizers, Divya, Hira, Sharon, Dr. Rupesh, and Abhi, and every one of us who had helped to put this course together. I'm thankful to all the giants in spine surgery who have actually come here to teach this course on a Sunday, which is usually a family day. And also want to let the participants know that this whole video is actually available on YouTube. Should you wish to see it again later on in your spare time, or if you want to wish to share it with your other colleagues. With this, John, I think I'm going to end the symposium right now. If anybody has a burning question, just one or two for one of our participants, please come up right now and tell the question.
Yeah. Hello. Dr. Parthiban, yeah.
Go ahead.
Dr. Roger, it was excellent talk, and really enjoyed that the talk on navigation. Definitely, navigation has changed the minimally invasive spinal surgery. That's what I feel, but it's very wonderful that you are using double microscopes in 2 ways so that it cuts short the time and the navigation procedure becomes much easier. It's very wonderful. Yeah, nice.
I would also pass on extend my thanks to all the speakers for taking your time on Sunday, and all the panelists. And please, means if you have any suggestions to improve, or what you want to like do for the next time, or any comments, like you can, you feel free to pass on the information to us and comments to us, so that we can do better in the next online symposiums. So thank you all.